welcome to Breakout Session 4. One of the things we wanted to do is provide an opportunity for representatives of health centers who are coming to this, or PCAs, representatives to hear the health center perspective. So, we are making this a collaborative opportunity, this entire conference, but we wanted to make sure that we had a session dedicated to what the perspective of the health center is as being a part of a CIN or as part of value-based care and what that has been as a PCA participant as opposed to a PCA employee. So we're trying to make sure that we have a well-rounded approach to this. My name is Joe Reilly. I'm the Chief Technology Officer and General Manager for Performance Solutions at Monarch Health Solutions, which is a group that we were lucky enough to be selected to help facilitate and organize this entire collaborative effort. So we've been working with the steering committee that Joe identified this morning for a number of months, and we'll be working with this group through all of next year to try to bring together and share ideas, best practices, and really understand what's happening at a detailed level. I am joined by some wonderful panelists. I'm actually going to have everybody introduce themselves because that's the first thing we're going to do. We made a decision as a group, and the panelists made a decision. This is a content-light presentation, so what we really want to focus on is discussion, dialogue, and running through just some key considerations that we identified in the planning process in terms of what do we think folks might want to hear who are on the journey or the perspective that might be most beneficial to share. So that's what we've done. Our hope is that you'll hear some comparisons, but you'll also hear where experiences have been contrasted a little bit. We also identified, as you'll hear in a couple of minutes, panelists who came from PCAs who are further down the maturity curves that relates to the formation of SINs and the taking on of risk through value-based contracts. And so we wanted to make sure that they've been there and done that and that you guys were getting that perspective so they're further along on the journey. So with that, I can hand it off. Do we want to just do a quick intro for each of you, and you can talk briefly about your health center, and then we'll switch to our first set of questions.
Sure. Me first?
Please.
I am Samantha Cannon. I am the CEO for Infinity Health. We operate in 11 counties in South Central Iowa and North Central Missouri. We're a little unique in a couple of aspects. Where the majority of our services and providers are behavioral health. We are an FQHC. We're a CMHC as designated by the state of Iowa. We've submitted accreditation to become a CCBHC with SAMHSA, and we operate one of Iowa's first access centers. So we're a little different with our service composition. We're also a little different with our payer mix, including the Medicare Advantage. We're about 20% Medicare, which is a little bit higher than some. Gives us a little bit of unique perspective. We've been in business since 2005, operate 11 locations, and I'm excited to share our experiences today.
Thank you, Sam.
Go ahead, Don.
Hi, I'm Donald Simila. I'm the CEO of Upper Great Lakes Family Health Center in Michigan's Upper Peninsula. We are a health center of about 230 employees. We cover a service area of around 10,000 square miles. We're very rural, distant, kind of a geography. We have about 40 providers. We provide medical, dental, behavioral health, MAT services. Our pediatrics and obstetrics are rolled up into our primary care. And we've been in the clinically integrated network as a member since its inception in Michigan, which was 2015. I was on the PCA board at the time, and it was kind of one of our projects that we started talking about probably 2 or 3 years before we actually actualized it. So,
I'm Chris Stewart. I'm with Katy Trail Community Health. We're located in West Central Missouri. Sedalia is our main location, home of the Missouri State Fair. And we have currently around a 4-county service area. Our health center started in 2005 after being a free clinic for about 7 years, so not unusual for health center development. We have about 150 employees and take care of just under 15,000 patients annually. We were also one of the founding members of our clinical integrated network in 2014 and started working on it a good 2 years prior to it actually starting.
Well, perfect. Thank you, folks. Just quick show of hands. How many health center representatives are in the room? Okay. And then is everybody else a PCA representative? Perfect. Just helpful to know the mix.
So Joe,
Yeah.
can I get a kind of a check the temperature of the crowd? So how many folks are currently in a clinically integrated network? And on a scale of like 1 to 10, where would you rate your level of maturity in that for those of you who are in a clinically integrated? 1, you know, 3. Yeah. Yeah. And then the rest of you guys are just kind of exploring the opportunity to kind of develop a clinically integrated network and okay. Thanks.
Yeah. No, appreciate the question. So as we go through this, we're just going to pose the questions. Our panelists are going to selectively decide what they want to respond to. We do want this to be interactive, though, so we will probably try to get through as many of the questions as we can and then do questions at the end. Is that okay with you guys? But especially for our PCA representatives, understanding, of course, that a lot of this work is done through the members, we thought it would be really interesting, as I had mentioned earlier, to share that perspective and talk about the successes, challenges, where things have worked, and what that dynamic was between the members as a collective, but also the individual members in the PCA. So that's what you'll see a lot of these questions are geared towards. One thing, and this we just brought up briefly, Don had asked about where everybody else was, so we wanted you to understand kind of where each of these PCAs were and the members relative to their journey in value-based care. So who wants to start just in terms of describing the types of contracts that you guys have in place today, upside, downside, et cetera? Whose preference is it?
I'll tee it up. So Michigan Community Health Network was formed in 2015. The network is, right now I think my notes are a little old here, but I've got 33 independent health centers that are members of the network, but right now I think we're closer to 39 of the 44 health centers that are in the state. We're all FQHCs. The Primary Care Association is a member of the clinically integrated network, but not a voting member. We hired our first CEO in 2016, and our management has changed since then. So we initially started as 2 separate organizations. So we incorporated as a LLC with the network, and then the PCA had its thing. You know, it didn't work really well, and we integrated leadership and management, really a blended model where our CEO of the PCA is also the CEO of the network right now. So, and we purchased a lot of support services from the PCA. So IT support, financial support, data integration support, IT support. So all of that kind of comes through contracts from the network through the PCA, although we do have some dedicated staff that are in the network. We have an executive director. Russ is here today. Right now we have about, I think 30 of the health centers in the network participate in what we have 3 value-based agreements. And those are we've concentrated with Medicaid health plans. And so we cover somewhere in here about 400,000 Medicaid lives, within that network. So on a large scale, when you think about the clinical integrated network, which is separate from our value-based contracting arrangements, our network consists of all of the health centers that have stood this up. So one of the challenges we had on the front end was actually capitalizing it. So we had to figure out how we were going to get it off the ground. So we asked all of the members to sign a participation agreement. We all kicked in, I think at the time it was $10,000 to buy into the the organization, and we became owner members, and so that capitalized us on the front end and helped us to kind of bring in some staff and purchase some services to kind of move us forward. So I don't know. That's enough of the. Why don't one of you go?
All right. We were actually a founding member of Iowa Health Centers for Accountability West in 2012, and that really was our planning phase, for lack of a better word. Iowa Health Plus came to fruition in 2014, and it's been a work-heavy journey since. Across the network, we currently have 400 providers, about 58% of which are medical, and 72,000 Medicaid lives, 204,000 lives total. And we just entered into the Medicare Shared Savings Program, so we've got just under 7,000 lives in that program as well. Our contracts currently are upside and downside. We have a similar structure to Don's group. Iowa Health Plus shares a lot of the same staff as Iowa PCA and In Concert Care, which is our HCCN company in Iowa. The CEO for the Iowa PCA is the CEO for our network. We have 11 of the 14 health centers in the state are members, as is the PCA, and in Iowa Health Plus, the PCA can vote. Gosh, what am I missing?
I'm going to say ditto to what both of these folks have said, except I don't have the data about how many lives, how many providers. I do know that 26 of our 28 health centers are members. We started out with 22, but it has grown over the years. We also started in 2014, and we have we contract with 3 Medicaid managed care companies and 1 private. When we started, we entered into a Medicare Shared Savings plan very early on as well, but decided not to continue down that path when that initial 3 years was up. But we are looking at existing ACOs as well to consider joining too. We are also a for-profit. We started out with separate administrative functions, and our CIN almost imploded as a result. And so now the model is very similar to what you guys are talking about in terms of the PCA CEO is the CEO of the network as well. And we also have an HCCN that is actually managed by a PCA employee as well. So there's a real synergy amongst the 3 organizations. And I think we only have 1 unique staff member, and she's actually here, who is the Director of Clinical Integration. Yeah.
Perfect. Thank you, guys. So starting out, just understanding kind of the characteristics of the networks that they're participating in, so give you guys a feel for the payers, the number of lives, but you can see some similarities as it relates to both the formation and journey. One of the topics that we had explored in prep for this as well was why they made the decisions they made to join us in as members. And so we thought that was important to discuss that. So we're going to ask everybody to just share in terms of what prompted that. And then in the role that each of these individuals is as the chief executive of the health centers, we know that it doesn't stop with their decision. It's really, there's a whole set of stakeholders that need to be engaged around this decision as well. And so much of, and I think where a lot of networks are is, you know, everybody agrees it's a good idea, but how do you get everybody aligned? And so we wanted to explore that concept of around alignment and give you guys the perspective of how that happened for each of our panelists. So I hand it back to you guys. Who wants to start?
I'll start. What prompted us to decide to join? As an organization, as a member of the Primary Care Association, we have been talking about it for years prior. So that time gave me time to educate our board about what clinically integrated network would be like, and how it would bring value to what we're trying to do at our health center. In terms of us getting buy-in to our providers, I'm going to say we didn't focus on getting buy-in from our providers. We've been very focused on implementing a patient-centered health home model, and that's much more interesting to providers than value-based contracting. And so our focus in terms of engagement has been around patient-centered health home, and that's really what feeds what we're doing at the network. The big thing that prompted most of our health centers to join was the idea that we could all have power in negotiating contracts with Medicaid managed care plans. Yeah, it was all over the place. So that was the big draw. And frankly, to create some consistency across our health centers, because we had some pretty high-performing health centers and some pretty low-performing health centers. And it took us a while to get to be transparent around that. But to help sort of, our philosophy was let's lift all boats. This is not a punitive, this is an avenue through which we can lift all boats. So that was very compelling.
Can we ask questions now or when?
Yeah,
Absolutely.
absolutely. Yeah.
I don't know if I should interject or not.
If you don't mind, though, folks, I'll bring the mic out to you just so the recording gets the question as well.
So I heard you say that you didn't focus too much on the buy-in for the providers. Do you feel like there were any negative consequences to that, or?
Yeah, I'll just speak for our organization. Our providers, whenever we start talking about reimbursement and really value-based contracting, they're not interested. But when we frame it in the context of really this is about being patient-centered and doing everything that we can do to be really patient-centered, that's very compelling for them. And so that's what we focused on.
I would just tag on to that if you don't mind. I wouldn't say we focus so much on the buy-in either. Our team believes strongly value-based payment it's coming. We need to prepare for that, and that's sort of the lens that we speak to our staff through. What matters to our providers, we've found, is where does this get us? So we really see this as the vehicle that gets them to see you can take care of Bob in whatever manner you see fit and that you can get Bob to comply with. If that means more care coordination for some and more appointments for others, this really is how you can get to the point where encounter numbers aren't dictating how you take care of your folks. So that's been the driver for our team.
Yeah, so, in my experience, we've really focused on quality, right? So rather than talk specifically about, a particular alternative payment methodology or a value-based reimbursement thing, we're driving quality outcomes for our patients, and it's really about developing the workflows in the practice that allow providers to be able to accomplish those types of things. So, I'm a big one for panel management and really try to understand, in totality as an organization. I can tell you, like, I have 2,100 diabetics. I've got 6,130 hypertensives, right? And so I also know what my percentage of patients that are not in good control and a number one, in both of those categories. And so getting that macro level understanding of the patient panel down to the provider level and the panel size, and helping them to, one, achieve good outcomes for that patient, also then ultimately helps us perform better in a value-based environment, right? So
That's the buy-in.
yeah,
That's
and so
the buy-in.
if I start talking about reimbursement with my providers about, okay, there's X number of dollars on the table and we're going to get it, they want a piece of that pie, right? So no, I already pay you, right, for the work for this. I don't want to have that conversation with them. So they really they're into the quality and outcomes for their patients.
out of curiosity, what platform do you use to, like you said, I have 1,500 diabetics, or I have, just wondering.
So our data analytic engine is Azara, and so.
So is ours.
Yeah, you know, and it's been.
That's what ours is.
Yeah, and you know, it's a wonderful tool, real time. So some of the challenges that, I don't know, I know some of the challenges that we've had are all about helping our staff to really work at the top of their license, right? And so in order to be successful in an organization for us, in an alternative payment methodology or a value-based world, you know, it's like my RNs that work with a particular provider or in a pod with a panel of patients. Do they have the information that they need to be able to kind of like in real time understand the scope, right? There's 934 patients assigned to this practice. You know, in that practice, this is the age cohorts. These are the people with the chronic diseases. These are the ones that really struggle. Here's the social determinants of health. And so if they can lead at the practice level, at the morning huddle, and maybe meet periodically to kind of talk about, well, let's try to achieve better outcomes with this registry of patients that's not doing so well clinically. What can we do to intervene? So is that CHWs, it's care coordination, case management. Those are difficult. I do want to say one thing though about, because we were talking about driving quality. I mean, and even with Suma and Jen were here, I missed an opportunity, but this whole transition for us is almost generational. We've been talking about value-based care and the transition for 20 years, right? And so we're moving along this continuum, but we're still living and getting paid in a fee-for-service world. And so the challenge for us really is how do we pay and stand up the services that help support a value-based contract? How do I cover the cost of 6 CHWs, and how do I cover the cost of nurse case managers? How do I cover the cost of a really well-educated and committed quality director to be able to drive the workflows and do the things that need to be done when I'm getting paid on a fee-for-service basis, pushing patients, you know, and it's really pushing that throughput in the office. And so, I don't know if I'll just go on. I'm a little bit different than these guys, right? So, in a sense that I've been the chair of the CIN and the Medicare in our organization since 15 when we started it, and I was on the PCA board at the time. But I saw my organization join the clinically integrated network, paid the upfront money, but I don't participate in any of the contracts. So where I live, I'm kind of like really disconnected from the rest of the state, and I don't have any members that are living in my community that we contract with. But I saw it, and my board saw it along with me, that as a statement, as a member health center in the state, as a leader in the state, we needed to invest and demonstrate that this was an important thing for all of the health centers in the state to participate in. So.
Thank you so much, John. And Sam, you guys have a different system. I know Azara was here. Arcadia is what you guys use, correct?
Yes, indeed.
So I just wanted to share that little difference. Saw a couple questions.
I just wanted to see if you could state a little bit more in the beginning about your structure. I understood you just say your CEO is the same as your SIN CEO. Did I understood that correctly?
I think that's true for all.
That's
Yes.
fulfilling the same role?
Yes.
Okay, so it's the PCA?
It's not the same
No.
role, though. I mean,
Okay.
they're two different.
Same
person's
they're two
wearing
different-
both hats.
Yeah, same person's wearing both hats.
Right, same person, but that's your PCA CEO,
Yes.
and then your SIN CEO. And one of you said that you did it another way and it imploded.
I said that.
Okay. Any reasons?
Oh.
Specific? Could you give?
Yeah.
No?
I mean, do you want me to talk about that? So when we started, we had a board of managers of 7 members. And we agreed that that was going to be the model that we used. We are also an LLC, and we decided we were going to have a board of managers. And we members of the network voted on those board managers and agreed to put them in place. A critical mass of those board of managers did not view ours is called Missouri Health Plus, did not view MHP as in the same way that many of the other members. They really saw it as an avenue through which they could make money. So the whole notion of valuation of the Missouri Health Plus was really important. And there was no movement really on clinical integration. We didn't have contracts for probably the first year and a half. And we could, I mean, it ended up that we literally, the members said, nope, this has to change. And, you know, it had a significant impact on our state. We had one health center decide that they weren't going to be a member of the PCA anymore. There was a couple of members who were threatening that as well. But what ended up happening once, and let me just say, there was no communication between the network and the PCA, none, which doesn't make sense at all. And no matter what we as members asked for, it just wasn't happening. So, I mean, we insisted that change, and members left the board of managers. They moved on, or sent the CEO of that Missouri Health Plus on his way, and then we began operating in the way that you guys are operating. It was a pretty traumatic time for our state, and it put a huge burden on our PCA CEO to sort of smooth over, and it probably took about a year, a little over a year, for that to actually happen. But we feel like we're firing on all cylinders now.
I honestly can't imagine it being any different, just
I
because
can't either.
this way you get the unified voice, you get the unified direction, you're moving the same way together without competing priorities. I can't imagine having a different kind of setup.
I mean, we had circumstances under which the CEO of the network was communicating different advocacy things at our state legislators, at our state, versus what the PCA was communicating. And we had legislators coming to us saying, what the hell? What's going on? You know, so, I mean, it really, whew, it was a tough time.
Congratulations for getting over that. So I have a question. Before you all entered into your CINs and your contracts, because you know, the quest is to get as many FQs involved. And as you mentioned, not everybody's really at the same level at that particular time. And then the other thing that also keeps coming up as question is, well, don't we have to be really level set or rebased with our rates before we enter into something like that, given the risk category? So was that ever a discussion before you actually entered into your contracts in terms of, let's look at, try to work with the state in terms of people's rates before we get into now assuming more risk and not everybody's being paid around the same, and there's, you know, big roller coaster sometimes in those gaps?
I've been complaining about the state not rebasing our costs for at least 10 years, right? So it really didn't play in a significant. Michigan is pretty consistent across the board, although there's a urban versus rural kind of a geographic factor. You know, our PPS rates in Michigan are based off of the 1999 cost reports, just like everybody else's. Wisconsin has some, you know, I think each of the health centers has their own cost-based reimbursement. None of that really, for Michigan, it was the playing field was relatively level from that perspective, and we all knew kind of what we were getting on the front end, and there's an opportunity for us to actually gain some revenue that the state was paying to these for-profit health plans that were distributing their profits off into shareholders, right? So in particular where I live, a for-profit health system owns 3 of the hospitals and the only tertiary facility in the region, but it also owns the health plan. And so the health plan makes money. There's a quarterly distribution of profits that come out of the health plan and go back to the for-profit hospital. Even though they're separate corporations, they've done a nice job of kind of disguising that. But you know, there was a way for us to try to actually benefit from the work that we do with that patient population. So it's that was kind of the.
Go ahead.
I might be a little different. I actually have no idea what the other health centers in the state get for their PPS. I'm confident they don't know mine. We were encouraged when we started the work to apply to have, I'm not sure what the right word is, to request the state relook at our rate, provide any data that had changed since they had last touched our rate. I think for us that amounted to like $11 more per encounter, which is $11 more per encounter. We'll happily take it. So we were encouraged to do that. We work with Katy on the center level to complete those applications so that we were starting from a good point for us. But no, our PPSs were not in any way aligned. I think for us, for our health center, I'll just speak for our health center, it was where do we think our needs are going to be best met? Where do our interests align the best? This was sort of in the works, so we had the opportunity to join a local ACO with our neighboring hospital, and we passed. We waited, we held out for this. And one of the bigger health centers in the state that isn't part of Iowa Health Plus has an ACO that works quite well for them. He's content there, and that makes sense. But for us, it really was, where does our work best align? How do we see us advancing the most? And it was holding out for Iowa Health Plus.
And we don't have a PPS rate. We are the only state in the union that still has an alternative payment methodology for Medicaid. So we do annual cost reports for which are.
So do we, yeah.
I know, yeah, but that's, I mean, at the end, they owe us or we owe them.
We have 2 counties in Missouri. Every year we have to pay back about 40 grand.
Yeah. Oh, it's just.
Yeah. I did not have that, Chris.
Medicaid.
Both.
Oh, I mean, they're both,
Yeah.
but yeah. Well, we have PPS for Medicare, obviously. Yeah.
So you had mentioned in the middle, sir, that you guys don't share any of the savings or incentivize your providers. Do any of the other? So there's no provider incentives, staff incentives. Do you do incentives at all? But they're not related to shared savings?
No.
Can you speak on that?
Our incentives are both quality and productivity based. So about 1/5 of what the care team can earn is how many patients are you seeing, which will happily change when we make it to value-based contracting and are done with the PPS. Not that I'm not grateful for it, but I can see something better. So about 1/5 of their incentives are based on that, and the others are quality measures. And we might line those quality measures up to align with the Iowa Health Plus work. Maybe it's a UDS area that we need some more work on, so we have them focus on that for a quarter or 2 quarters or how many ever quarters until we get to where we need to. But no, there's been no discussion about them getting any piece of the shared savings, although we do earn it. And we're pretty open with how we spend our shared savings, and we are investing in those care coordinators and the referral specialists and the membership specialists. And all of that lightens their load, so they do see the benefit there, but no, we've never had any conversation about shared savings being anything other than reinvested.
Yeah, it's inevitable that you will have that conversation, you know, so I've always, so again, remember, I'm not part of the Medicaid value-based contracts that Michigan Community Health Center has, and we, as a network, have redistributed tens of millions of dollars back into the health centers that do participate. But you know, our commercial payers have a value, you know, based reimbursement incentive that they pay back. Blue Cross Blue Shield of Michigan has a physician group incentive program. You know, the health plan locally has a small amount. You know, the state, we participate in some one-off programs with the state opioid health home that does a PM for an enrolled patient, and a MyCare program that does a PM. So some of those all come back, but I historically have always withheld about 20,000 from my providers' comp and redistributed that based on whether or not they hit a quality measure. So, 90, I don't know, so let's just say childhood immunizations that, your panel of patients, 95% of your kids you'll hit your immunization target for the 6 months, and that'll earn you $10,000 bucks. And then the other 10,000 is really a good citizenship, behave well.
Behavior, yeah.
Behave well, participate in a change act, a change initiative within the clinic, lead a change initiative, is a kind of a way to do it. But at some point, I mean, if there's substantial dollars which really there aren't at this point, I suppose, but at some point there are. You, as an organization, as a health center, you have to stand up the quality department in order to support it. You've got to have the CHWs and the care managers and the IT systems and the data analytic engine. All that costs money in order to be able to participate and be part of this. That's where, having a partnership with the PCA has really been beneficial, because we've done group buys and we've really taken the opportunity to capitalize on the HCCN programs, that the funding that the PCA gets, and then the Quality Improvement Network. And so those resources that are at the PCA level, we've been able to, one, not only as a health center benefit from the TA that comes from that, but the network has also benefited from that. And so with our governance, you were talking about how you're structured. Our PCA has a board of directors. Our CIN has a board of directors. And so, those of us that are on the board for the CIN treat it as a business. So we make business decisions about, compliance. And then so there's somewhere in all of this, what do you do with members who are not performing well in a contract, like their clinical performance measures are below a benchmark, so the network has invested some of its money in consulting to support some of those other health centers, right? So we put those people out into those health centers to support workflow redesign, assist with training and education to help bring them up to a level that allows us to achieve greater savings within a value-based agreement, right?
And just to piggyback off what Adon said too, and we may be an exception between the two of you, but one of the things that, let me just say, we do the same kind of thing, but we use really the PCA, and if the PCA doesn't have the subject matter expert at the PCA, then they're going to reach out to other folks to help support. But just to say, one of the things that was surprising to us once we got transparent is just how low performing we were, right? We thought that we were the cool kids on the block, right?
Yeah.
And we're not. And that is a tremendously valuable thing to see statewide, because we're transparent about it. We all know where we are. And
so, for instance, chlamydia screening across the network, right? So we have some high performers and some low performers, right?
And
so how do you get that? How do you change
so what it involves then is that we create the spaces, both through the PCA, well, mostly through the PCA, to help educate health centers and share best practices and do that kind of activity, again, with the philosophy of lifting all boats, right?
You guys just beat me to it, so I just put this up on the screen because we started. No, don't, not at all. So we were just starting to touch on some of these topics, though. The services and supports for the network relied on most heavily, best practices. So no problem. I just wanted to throw this up on the screen since you guys were getting there. And you started just on the last one, Chris, talking about how to drive consistency across the network as well. And I know we have an outstanding question out there as well.
I was wondering if you had any bad players in your state, and if you did you have to remove them from your network, or how do you handle people who just
We haven't come to that yet.
okay?
We did it in the first round when we imploded.
Yeah.
We did it. We took care of it. Or they took care of it, I should say.
They opted to.
They opted not
They
to
opted
participate.
out. Yeah.
So nobody had to get rid of somebody that you.
And we
haven't.
actually, I mean, we've made the decision that that's really not what our network is about, right? Our network really is about improving across the state, right? And, you know, we've had this question on our agenda for years and years. So what's the consequences for folks who don't meet their clinical quality metrics or their
Access.
primary care penetration rates? We don't take a punitive approach.
Not in the measures of the clinically integrated network. I'm just talking about people who aren't in line with your mission, who
As in like employed staff or external organizations.
okay, another CEO perhaps.
That we
Like-
haven't seen that.
Yeah.
We haven't either.
We just have
No.
like a couple in our state that they really aren't on board with it, but I think that they stay in the group to be in the know. They want to know what's going on and make sure they're not
Sure.
missing out on anything. But they really don't want to do the work. And they put barriers up for us advocacy wise, legislatively wise. There's a lot of trouble that comes with that mentality, which is a negative one. Most of our members are positive, but you've never had to vote anyone out.
No.
I'm not
No,
talking about
and
voting them out because they
you know,
perform poorly.
So our bylaws have language in it about how you would remove a member, right? Should it come to that. I mean, that's, that's expected. For a health center that repeatedly has demonstrated, say, non-compliance with programmatic and organizational goals, and not responded to remedial action, at some point you have to have that conversation, right? Just like with an employee who's underperforming and you do corrective action and you kind of move it along. I mean, it's the same principle. We just haven't got there. And, philosophically, we're like you. It's like, what can we do to help support you to become more efficient, better at what you do, so that, we all benefit from your participations. We all, we have a common goal to be the finest, most comprehensive primary care network in the state.
Exactly.
So,
I hope you guys don't run into that problem.
I would just say general to some of the, I'm sorry. Did you ask another question? Oh.
No, I said I hope they don't run into that problem.
No, some of what I think, just at large, some of the things that we've seen, it depends on how much shared downside risk there is in a network as well. As those levels increase,
there'd be more pressure to do something.
Sure. If lack of member performance means you're either not going to get what you could have gotten or you're losing money, that chance, yeah.
The numbers are good. They're just
Yeah.
difficult. I mean, they impede everything we want to move forward with. We have to get over the barrier
Yeah.
of that.
Well, and I think that is so much more a process of planning for the network. And then if you are onboarding new members, I mean, we took a lot of thought into the criteria of becoming a member. And I think that the very difficult conversations that we had as we were planning to become Missouri Health Plus helped prevent some of that. Yeah, and health center CEOs can be a bugger, and
Hey, watch it.
and my PCA CEO is back there. So, but having folks engaged in the network and our PCA be able to really help us navigate those waters are pretty important. Sorry.
No, don't be. We had a question in the back of the room.
I have a question. I'm from a PCA, so wanting to hear really what got you guys on board, but I think you answered that early in the talk. But what were some of the barriers? I'm thinking about, so we have always like a smaller group of early adopters that are ready to go. And then we have the middle group, and then we have the laggers. But how did you really encourage those in the middle to join? And was it you all? Was it the PCA? Was it, like, how did that look?
You know, in Michigan, I think it was a combination of folks, right? So the long-standing CEO of Michigan Primary Care Association, Kim, many of us remember her dearly. You know, she and I and some of her staff, Philip and others, you know, the writing was on the wall. We need to start moving in this direction. How do we educate our membership? We included it in our annual, you know, on the agenda for presentations during our annual meetings. We, you know, created communication opportunities and webinars on, you know, what's coming down the road, talked about how this is going to impact our delivery system. And then, you know, at the simultaneously started to prepare the documents, you know, the participation agreement, forming the corporation, got legal advice, you know, started to look at how we were going to kind of put that organization and stand it up. You know, the big issue is obviously, you know, if you're going to ask people for money, what's in it for me? You know, so that was kind of a multiple conversations at many different levels. So, you know, all member meetings, you know, it became a topic. And so, and then at some point you just have to drop the mic and say, okay, here we go.
In or out. For us, it's a combination. We're blessed to have a very forward-thinking PCA. Erin has done a fantastic job really conveying. We can be at the planning stage, we can be part of the group that's helping develop what this could look like in 5 or 10 years, or we can be dictated to because we chose to adopt slowly. And that's really resonated with a lot of us. I would say the second big piece is there have been hard conversations. There have been folks that are varying levels of readiness. And really being okay with it's a safe space to talk. Let's lay it all out there and let's discuss what challenges we've had, what challenges we foresee. One area we've been particularly careful with since we've been discussing remediation when needed, we're really, really thoughtful about our participation standards. Could this be something that we worked together on as sort of a best practice, or is this really a deal breaker for us? And so we spent a lot of time discussing and fine-tuning what are the things that really matter, and can we all commit to those while still maintaining our autonomy as individual health centers. So we spent a lot of time there too.
And part of our, I think, you know, that engagement and it ties into our governance. So we have, you know, the network has a board of managers, there's 11 CEOs and a clinician manager who chairs our quality committee. We have 3 committees. Each one of those committees has 13 members, you know, and so we look for distribution across all of the members of the health, the network to, you know, offer up those staff members to participate in that. And those meetings and the discussion are, you know, carried forward into the board, but, you know, and then back to the health center. So I think the more that you can communicate and engage with, you know, member health centers or CEOs and get them involved, the better along the way. It's a time commitment, but it's important, I think, to build that sense of universality, right? So that's what we're really talking about.
I mean, I would just say the paradigm shift is, you know, as a CEO, your number one concern is your health center, right? But the paradigm shift is that you have to be not only engaged, but really make a commitment to the network, especially if you're trying to do a statewide network, right? So decisions sometimes are made that might not be in the best interest of the health center, but that are absolutely in the best interest of the network. And you've got to be willing to do that. And there are some health centers that are not. But those are the kinds of conversations that we had in the planning.
One really cool activity I'd like to give Joe credit for that we worked through on our road mapping process was we went through this list of tasks, duties, responsibilities, and had some honest conversation about, is this something we need to continue owning? Is this something that health center needs to be able to control individually? Or could this be a PCA function? Could this be a CIN function? Could this be something we buy together or we share together? And it was really important to pull out for the 11 of us, what are the things we're not willing to let go of? What are those, this needs to remain in local control kind of things? So that's an important conversation to have too.
So I'm just going to throw out the last set of questions, just for food for thought for everybody, and then we have a question in the beginning of the room, or in the front of the room here. Go ahead, please.
Yeah, hi, thank you. I wanted to pick up on what you said about, I was sort of glad to get out of PPS. So I wanted to get at this so Adam talks about in your negotiations, you have certain leverage, and leverage is often from the statute, right? And so the security of the PPS and the APM for Medicaid and for Medicare. So I'm thinking about Vermont, which is in an all-payer model right now. So can you talk to me about how you made that shift from the stability of the PPS to something different? And is there a place where you had the PPS as a base and then there was sort of a risk corridor of an upside or a downside risk?
Sure. We are still paid by PPS, and we are working through the various stages to get to full value-based contracting. I might be a little unique in that I am so excited about the possibilities that value-based contracting brings. I feel like we do so many things as health centers because these are the steps that we have to follow. These are the encounters we have to have in order to pay the bills, to pay the staff, to reinvest in ourselves. And long term, given the rising cost of healthcare, that's just not sustainable forever. I do believe that if we're early adopters, if we're engaging now, we do have the power to shape some of that. I mean, how many patients do we care for across the country? Right. Millions and millions. So I think there's strength in numbers. I think we're uniquely positioned to really start shaping things if we jump in early. And I think the end result is freedom to really treat the patients in a holistic manner that doesn't have to care about how many times a year you see them, whether it's 20 or it's 2. So for me, that's sort of the driver.
Really moving to a fully capitated system.
Yes. And not everybody shares my sentiment. I know that, but that's what I'm excited about.
And I don't know necessarily, like in Michigan, we have some PMPMs that we live with, but we also do PPS. So we're billing for encounters. We're talking with the state right now about an alternative payment methodology that would give us a fairly substantial PMPM that would almost like almost like capitation, full capitation, but not quite there. That does relieve you of the demand, the fee-for-service demand, the throughput demand, if that base price, that PMPM, is enough to live on, right?
And that's the question that I have, which is, right, you have this stability in terms of your revenue, and then
It's predictable and budgetable.
Exactly.
Yeah.
So when you move away from something, is it as predictable and budgetable, and can you get that
Well,
additional
and so
quality?
it's
It definitely goes back to your ability to do penetration, penetrate your market, and what you're able to do in terms of outcomes for the contracts. And while I'm actually with you on this, but I know we are a long way from that because of our performance. We need to do a whole lot more work around our performance on both of those things before we can even be thinking seriously about that.
So all of it ties to patients are going to be able to enroll and disenroll, right? Opt in or opt out, and keeping that patient engaged. I mean that's the unknown, I think, that I hear you saying, right? So right now, I mean, I can build a budget based on my provider FTEs and X number of visits per year, and I'm able to kind of staff accordingly, anticipating that. Like our opioid health home and our MyCare program that we're doing as a pilot with the state. A year ago, I had I don't know, let's just say for conversation purposes, 500 enrolled participants where I was getting a PM, and it was like, wow, this is really nice money, and it's on top of any PPS that we might be getting. But then all of a sudden we lost the CHW, or somebody forgot about the program, and patients were becoming disenrolled because they hadn't been contacted, and it went from, wow, that was a lot of money, and like, whoa, what happened to that program? And so then that's that unpredictability, and so there's a level of maturity in the health center that has to be present in order to be able to participate in these things too. So.
And you also have to have a really good grasp on where do your costs lie. If you're providing a physical, exactly what does that cost in staff time and dollars? I think that's an area that we're still really working on. Years ago, I went to a fantastic presentation that Andy Principe did, and it was on how do you quantify what your value is for this service or this screening or all of the little things that we do. How do we put a dollar to that?
Yeah, so there's, that's the first question. How do you refine approaches to use funds received to further your mission? Well, like in our world, we don't have a payroll system in a general ledger that talk to one another to actually do cost accounting, right? So in other words, if I want to really understand the total cost of care, cost per medical visit, or the cost per dental visit, or the cost for behavioral health visit, I'm not sophisticated enough to be able to do it. Our systems don't talk. I don't have a barcode scanner for every time somebody pulls a Band-Aid out of the, out of the cupboard to get that in the inventory system to really build out a cost per visit. So that's a level of sophistication where I think as health centers, if we're going to be successful, we've got to get there.
I mean, I'm going to just piggyback on you. You're talking about cost, but I would also talk about just data integrity in your EHRs and how to be able to standardize that in a way that, I was just telling people at my table at lunch, we do an audit annually for our drives to be able to pull the data, just to make sure that it's being pulled. We need to do that monthly, really. We really need to do that monthly.
To test it, to see if it's accurate.
Yes, exactly.
And I think too, we have learned a lot about all the PCAs and all the health centers and all the risk-bearing contracting going on. I don't think there's a single instance today where there's a full capitated risk arrangement in existence across the country. And so, and what I would say is there seems to be this very natural progression from pay for reporting to pay for performance to upside downside risk, and there are limits to how much upside and limits to how much downside. And so it's not a quantum leap from contemplation of the network to having that level of risk. So I think and you guys would agree, right? You've seen those contracts evolve over time.
Absolutely.
The payers ask for new things. But once you know you can control the cost and quality, or at least you feel comfortable that you're getting there, that opens opportunities for greater and greater levels of risk. But it isn't until we see, the Medicare Advantages of the world and some of these very sophisticated contracting mechanisms where you're really truly taking on all of that risk. That's a rarity today, I would say, for sure. It doesn't exist within 34 PCAs that are part of this group.
I have a couple sort of operational level kind of questions as someone who's more on the ground with the health centers, trying to support them in the work with Wisconsin. So one is we have kind of the dirty word right now, which is attribution. And so I'm kind of curious how you guys have wrestled with that in your contracts as a health center. What's your perspective of these patients that have been attributed to you but have not found you yet? What's your attitude towards them? How do you work with them? And then a second question, if I can sneak it in, is with the network on the data side and the performance side, are there things that you look to your network to say, we need you to push quality priorities, like we need you to prioritize out of the 30 metrics, we need the network to do that, or we want control over where we prioritize, and just a little bit of how that kind of works. Sorry to squeeze in two questions.
Those are some pretty heavy questions.
I'll start. I'll start with the second half because it's a little easier. We actually have a clinical workforce committee as part of the CIN that has a lot of the conversation about what metrics should be in the contracts. We also have a fierce team at the network that's negotiating those contracts for us. So right now we've got some alignment between our contracts, which is great. And then our clinical quality committee is really who takes those, they dissect those, and they help pull out some best practices for our health centers. The data, I can't stress enough how important the data is. There's something powerful about seeing how you stack up to your colleagues around the state, not just for us, but for our providers. So if they see, gosh, they're doing 3 times better than me in Fort Dodge, that's motivating. So I would add that too. Attribution. It's a struggle in Iowa too. One thing that we've done to try to tackle it, although we haven't made it far enough to see is this really going to do the trick, is we're investing in membership specialists, and those are folks that can meet with our patients and say, you know, you're actually attributed to the health, to the clinic down the street, but you come to us all the time. Can we help you make that change? Or, gosh, Bob, you've been on our list for 3 years and we've never seen you. Could we help get you moved to the provider you're actually seeing? So it's early enough that I don't have any good data for whether or not it's going to do the trick. It's in the health center.
Yeah. We've been doing that for 2 years. And our goal across health plans is a 25% penetration rate of those who are attributed to us. And we just barely made it in 2021.
Is that your gateway to then the next level of savings?
Yes.
Yeah.
Yep.
So those access, you know, so a lot of that's built on, you know, you have to jump over a hurdle first and be successful in order to make yourself eligible for clinical performance quality measures. So, you know, the multiple payer quality performance lists are the bane of our existence. Right?
Oh.
I mean, just like you've got, somebody told me they had like 16 health plans or 20 health plans.
Wisconsin.
Every one of them,
Nice.
you know, I mean, you know, I guess Medicaid
How
really.
many quality measures do you have? Yeah.
Right,
Pull them out.
so at some point, you know, we all say in our, you know, in a perfect world, we'd have a uniform standard list of outcome measures that we're all going to track and we can all live with. You know, I don't know if that day is coming.
Our
so.
next conversation, because we've been talking about this internally and in our contract negotiations. Absolutely, we're trying to align in our contract negotiations. But just at our last MHP meeting, which by the way, the Board of Managers does not meet independently. It is completely open to all of the members. It used to be that it would happen in isolation. Now, there are no Board of Managers separate meetings. It's all of the health centers, even though we have a Board of Managers. Anyway, we're now talking about going to have a discussion with Medicaid about the impact that this is having on health centers, and to see if there's anything that they can do in their contracting piece with them to align more effectively.
So as they build out their RFPs,
Yep.
can they start building language in that
Yep.
supports, you know, consistency in those measures, so
Yep.
that, you know, if you have multiple health plans in the state. So that's a PCA advocacy thing, you know, legislatively being able to talk to them. If you have you know, you have some talking points, and when you do your legislative visits, you know, with your state legislators, you know, here's the things that are important to us in this, you know, in this delivery model. These are the dollars that we can save you, you know, if you only cooperate, right?
I was going to add to one thing. What we have seen is as networks evolve, is a higher evolution of the funds flow models to really align with very directly the network incentives, right? Because there are different schools of thought around that, right? There are mechanisms that distribute based on ownership. There are mechanisms that distribute based on the things the network does well, the members get paid for. There are mechanisms that say we're going to pay you for your cost and performance regardless of how the network's incentivized. As long as we have distributable funds, we're going to pay you for doing a good job and meeting the benchmarks that have been established in the payer arrangements. So I just say that because when we think about things like performance, and we talked earlier about, you know, governance and how do you manage underperforming partners, although it sounds like those aren't exactly the situation for your network, incentivizing the things that lead to higher upside through these value-based arrangements is a very natural way to try to govern behaviors, attitudes, et cetera. And at least in my experience, that evolves over time as well. So it doesn't always start there. There's a sense of a lot of equitable distribution initially, but if you are doing the vast majority of the work and driving costs down or driving quality up, folks have a tendency to want over time to be realized. So I just wanted to throw that out there as a general theme as
Let
well.
me add two other things to this attribution conversation as well. One is that we started to be able to look at our clinical metrics by, yes, it's by attribution, right? So we have a goal for all the people who are assigned to us. But then we started looking at where we are for the people who are assigned to us, who are actually our patients. And what we absolutely see is that we're doing so much better on those patients who we're actually seeing. So that's the kind of thing that we share with we use CHWs to do this. That's the kind of thing that we share with the people who are reaching out to folks, patients, to come to the health center, because we know, we've been looking at it now for a year, we know that that's the patients that we see are doing so much better than everybody else, the people who are not coming to us. And then secondly, on this attribution issue, we just started a pilot, and there are 2 health centers in the network that are piloting with 2 of the health plans. United Healthcare won't play with anybody, so 2 of our health plans have agreed to do a warm handoff to our eligibility or enrollment person, so that when they get somebody who's been assigned to that plan, or that person has chosen that plan, and then they're going to be assigned to us, they do a warm handoff to us. And so we're piloting that to see if that will increase our ability to improve our PCP penetration rate.
That is wonderful.
We just started that, so we'll see what happens.
The other thing too, and I know because I do a lot of work with my friends in Iowa, there's been a lot of analysis on that front. And is it detrimental to have the attributed but not seen populations, or are they costing us less? Is their quality worse, right, if they have conditions that qualify them for the numerator denominator measures, and you don't get to see them? You're unlikely to be able to control the closure of the gap. But I mean, there's been a lot of look at that, like, is it good or bad? And that varies population to population for sure. But it also, I think, can provide you with more leverage over time too, to really refine how that's done, so that your payer is, addressing the population you actually can impact. But it's not always downside, and I just say that because it depends on the numbers, really. So any questions anybody have a question that we haven't addressed yet? All right, well, we certainly have covered a lot of ground. We have about 15 minutes, and I say we don't have to use every minute. But I would love, and you guys covered a lot of this along the way. But if you guys don't have anything burning, and of course you're welcome to share anything you'd like. But I would love to know if you could just give me your top, let's call it the top 1 or 2 lessons you've learned along the way. If you had to share with the group, what do you wish you knew now or then that you know now?
I'll go. Years ago, when I started as a health center CEO, we saw what I would call a split between a group of CEOs that came up in the origination days, so late 60s, early 70s. And those folks were folks that put their head down, moved forward, did what they needed to do in order to serve their patients and be compliant, didn't collaborate with anybody, including hospitals or anybody, right? They just put their head down.
That happened in Missouri?
Oh, Jesus. and then another group that really started coming into health centers in the 2000s that were much more about collaboration, partnership, transparency, sharing information with each other and our partners, right? So if there is one lesson learned for us, it's about those collaborations, while incredibly difficult, even amongst our own colleagues, are what makes our network successful. Our willingness to be vulnerable in terms of what's going on in our health centers, our willingness to be transparent, and our willingness to say to our colleagues, we're going to succeed together. We're not going to let anybody in this group not succeed. We're going to succeed together. And that, to me, are the main lessons. None of them are around anymore. No, there's one or two. There's one or two. One isn't on the PCA, isn't a member of the PCA, so. I can think of two, actually, that are still around.
Go ahead.
I would echo the need for transparency. I think any challenges or growing pains that we've had have been the result of either a lack of understanding or perhaps people wanted to be involved at different levels than they were. So we're an open book with regard to network activities and decisions. I think that's key. Patience, and that may sound silly, but I'm raring to go, and there are others that aren't in the same place. And so finding a happy balance between being excited about what's over here and giving the CFOs time to wrap their minds around how this is going to work and why if PPS is sort of working, why would we want to change that? Finding that balance and being willing to take the time necessary to invest the time necessary to decide together, I think is incredibly important.
And not to write off your colleagues because they are where they are, right? We had some of that going on, and that's changed, you know?
So I guess from our perspective, I would say that start thinking or figuring out how, you know, what's the organizational or the operational pathway, right, or the crosswalk that you're going to use as a network to access the necessary support services you need, and primarily how much of that's going to come from your PCA, right? So if you're thinking about forming a CIN and you're going to do it outside of the PCA, you know, that's a little bit of a challenge, and I think, you know, there's so much that the PCA brings to the table that supports the network, because basically all of the members of the network are members of the PCA, and so, you know, there's that synergy that kind of happens there, but there's no point in duplicating the wheel either, right? So I think that that's a big issue for us. You know, we started down that path. Michigan was blessed to have found, you know, this really experienced, you know, hospital, big system healthcare administrator who also ran a insurance company. So you remember what were those HRSA insurance co-ops, right? So we had Michigan Community, I don't know what the name of it was. I was on the board for the state insurance plan, but the CEO from that stood that up, and it collapsed, and we happened to actually all of a sudden have this vacancy and a need for a CEO for our network. He had relationships with all the payers, with the hospital association, was a wonderful negotiator. You know, so finding somebody early on in the network that's really a talented orator and a negotiator, understands the contracts and can really carry the flag. And it's like, this is, so we have an executive director, you know, that is you know, for the CIN, that works for the, you know, and reports to the CEO of the PCA. But you know, that's his job, you know, and so he was trained under the, you know, the right people, and it's helped move us along. I mean, I could never, I mean, and I'm a, you know, I could never have negotiated the agreements with the health plans like we've had somebody with experience doing that. So it's really, even if you have to buy that from outside the organization as a rep, make sure you get the right person to do that.
That's a good point.
Any parting questions, folks? Yeah.
I have a couple more. Sorry, guys. In your QI structure at your health centers, is your work for your integrated network and your pay for performance sort of contracts, is it married with any QI work you're doing around just general UDS quality improvement, or do you have sort of different teams working
As
on?
much as I try to have people pay attention to the scorecards that we get from the, from the state or from the ACO or, from the network, yeah, it's really just kind of narrow the focus. And then the work plan that the compliance and performance improvement team has is focused on metrics that we pull from those various places. And
We decide what they're going to be,
Yeah,
right? Because we've
yeah.
got so many. So it's almost I don't know, do you do it annually or do you do it?
Well, ours
monthly?
is actually rolling.
Oh, it is.
So
Okay.
we do a rolling quality plan that, in our health center that,
Yeah.
as a measure, kind of works itself off the list, we add another one.
Yeah.
So, and if we don't perform well, like say, I hate to say this, but the UDS data is not out yet, but, we went from, I think 19% in a not in good control diabetic patient population to over 30% last year because of what I think is COVID. And that's abhorrent to me, right?
Yep.
And so my staff hasn't seen that yet, but it's just like how do we correct that, right? And so there's lots of patient engagement, and that'll be on the list, so and it'll stay there until it gets fixed.
We have the same QI staff that work on both sides, and as often as we can achieve alignment, great, but it's not ideal.
No, and like I said, we select, and we do select from the plans as well as UDS, as well as we have multiple state contracts with deliverables, so we pull for all of those as well and create our own. I like the idea of rolling. That makes sense. Yeah.
Yeah, sorry, one other one. The other staff from your teams, your leadership team, or people doing the work, how are they, or how are they not involved with the various committees of the CIN? Do most things roll up through you, or do you have other staff involved in?
So I kind of, I don't make it a rule, but I mean, I put a lot of pressure. I have high expectations for my leadership team. So my expectation is that my CFO is on the contracting and HCCN board. My director of value transformation, that's relatively a new position for us. I expect her to be on the operations committee for the CIN. I have my quality director is expected to be on the quality committee of the CIN, but also on the ACO, all right, and also on the health plan quality. So they're busy making sure they're at the table when these things are talked about. So when we can put the right people in those seats, I think you have to do that. They won't understand any of this if they're not having the kind of conversations like we're having today, right? So
I would agree with that, but I would say for us, it's mostly the executive leadership. We do have director level folks involved in our HCCN, which also supports the network as well. So there is synergy there, yeah.
We're an admin team of 6, and everyone there has everyone on our team has committee roles, and then we have a few department directors as well that fill in those committees. One thing that the network does that I love is once a month, so I might sit on finance, and I'm always on finance, and then of course the board, but I get a report for all the committees once a month. So
Yeah.
Amanda does a wonderful job saying, here's all the work that everybody did, so I can at a glance know if there's anything I missed or that my team hasn't shared.
Yeah.
That's very helpful.
that's the other piece, I guess, that I push out the board packet, for the committees and the actual CIN board meeting to my senior leadership team, and when that comes out every month, the ACO board meeting minutes, all of those go to my
Yeah,
staff.
ditto.
Yeah.
Yeah.
So I'm sorry, I thought I had this until I just heard Don explain his structure. So the PCA CEO is also the CEO for the CIN for you guys, but
Yep.
not for you.
Yeah, it
You
is.
have-
No, it is.
Oh, it is. Okay. I
Yeah.
thought I heard you say you had a.
We have an executive director that works and manages our work in the CIN.
Oh,
But
okay.
he report,
He
you know, but
reports up to
he
the-
reports up to the CIN CEO, who also happens to be the CEO of the PCA.
Okay, and
Okay.
are your boards for each of the, so your board members, your directors for the PCA, are any of them crossed over, or is it all the same directors on the CIN?
It's not mutually exclusive.
Okay,
So there's some difference. So our state is kind of, you know, we broke our state up into regions, and I think there are 11 regions. So for instance, Southeast Michigan has, I don't know, 6 or 7 health centers, and they generally vote within that region for a representative at the PCA board, but also there might be somebody different at the CIN board for those members that are owner members of the CIN. So like in my region, I'm the only health center, so I always get stuck, you know, serving. So, which I, you know, yeah, for me. The violins are out, I can see.
thank you.
Well, thanks so much. If you guys don't mind joining me for thanking the panelists.
Thank you.